So when we talk about factors that affect our breath rate, we're talking about what measurements your body is taking to determine how quickly and how deeply you should be breathing. Bear in mind that for the most part, rate and breadth of ventilation does usually go hand in hand. So for the most part, when you're increasing ventilation rate, you're also increasing depth of breath too, which means the volume of air that you're taking in. Bottom line is, the most important factor driving this is carbon dioxide levels. So think back to what we talked about with transport of respiratory gases. How is carbon dioxide transported in the bloodstream? In what form?
Liquid.
Well, I mean, carbon dioxide gets converted to something else, right? What's it? Carbonic acid. So carbon dioxide, most of it, is being converted into an acid in our blood plasma. And so the main thing affecting respiratory rate is pH of the bloodstream. As carbon dioxide levels increase, our pH goes down, it becomes more acidic. And what does our body do to compensate for that?
Takes in oxygen?
Well,
or expels
the carbon dioxide. Now you're going to be taking in oxygen at the same time,
right.
But we'll see this on a later slide. Under normal conditions, oxygen is not playing a strong role in this. For the most part, your body's responding to carbon dioxide levels, or more directly the levels of hydrogen ions, but like we saw, carbon dioxide becomes an acid in the bloodstream, so it really goes hand in hand. So the partial pressure of carbon dioxide here. So we're listing carbon dioxide, but keep in mind that it's actually in that other form, carbonic acid, when it's in the bloodstream. And of course, like any acid, that gives us hydrogen ions in solution. That's what makes something an acid and causes the pH to drop. When pH goes down, respiratory rate goes up, and vice versa. When pH goes up, respiratory rate goes down. What we're doing is manipulating the carbon dioxide levels by either eliminating more or less of it to stabilize that pH in the good range. And remember, because we're monitoring pH more directly, we use that as an indication of carbon dioxide levels, but what we're really measuring is pH. We can adjust respiratory rate to changes in pH that have a metabolic origin too. Remember last time we talked about vomiting and how that can affect your breath rate too? So when our carbon dioxide levels change, that changes our pH and our body responds to that. We mentioned a little bit about hyperventilation last time. Hyperventilation is when breath rate goes up, but it doesn't need to. This can be like a nervous thing, sometimes for people, other factors too, but bottom line is what's happening is this person begins breathing fast for no reason, essentially. The body doesn't need that increased ventilation rate. And the effect of that is breathing off more carbon dioxide, really, than you should. And what does that do to our pH?
Brings it down?
Up, right? So you're getting rid of too much acid, essentially, so the pH starts to rise. And that can mess with you. You see here, cerebral vasoconstriction, ischemia, dizziness, occasionally keeling over can result from that. And so again, what's the instruction that you give people who are hyperventilating, the old folk remedy for that?
Breathe into the bag.
Breathe into the bag. When you breathe into a bag, what are you doing?
Using the same air.
Yeah, so you're re-inhaling that carbon dioxide that you breathed off, and it's supposed to help stabilize the pH.
It doesn't really stop you from breathing heavy though, right?
No, not necessarily. So if this has some kind of psychological origin, you really just have to get past that. This is, calm down essentially, this is meant to help stabilize the pH of the blood more than get you to stop breathing fast. So levels of oxygen in the bloodstream normally play very little effect on our ventilation rate. We're taking into account the pH of the bloodstream to a much higher degree. This may seem counterintuitive because oxygen is the stuff that you really need, right? But if we're simply monitoring the pH of the bloodstream and responding to that, it has the effect of keeping oxygen levels more or less consistent all the time. So there are peripheral receptors whose job is to monitor oxygen levels, and your brain can make changes in response to oxygen levels. It just doesn't usually work that way. The reason why is in order for your brain to respond to oxygen levels the same way it does to pH, it takes a pretty substantial drop. It says to 60 millimeters of mercury in terms of partial pressure to have an affect in ventilation. Do you guys remember what, or I guess you can look back in your slides, the partial pressure of oxygen is normally in arterial blood? It'd actually be in that picture you got right there in your book. Top left. There you go.
160? Is that the right one?
Partial pressure of oxygen?
I'm just looking at the pressure myself. It's got a lot of pressures on here.
It does.
I could start throwing out numbers, but...
You could. So we're looking at this picture here, right?
Right.
So here is that arterial blood, or in the pulmonary system. We're looking at somewhere between 100 and 104,
Oh, okay.
right? And that is, what did we say it takes to cause oxygen, a decrease in oxygen levels to affect respiration?
60?
About 60. So you're looking at a 40% drop in oxygen levels in the bloodstream before you have any effect on pH or on ventilation. And that's just under normal circumstances not really going to happen. Okay? Your brain is going to respond to pH changes well before you ever even get to this point. Here we see the relationship between those respiratory centers and the peripheral receptors. So we've got chemoreceptors to these things in two major locations. The arch of the aorta, right here, and the division between the internal and external carotid arteries, what they call the carotid body, which is right here. So those are the two major locations of peripheral chemoreceptors. These are the ones checking things like pH and oxygen levels and so on, and sending that information to the brain, and the brain will then decide if we need to make any changes in ventilation rate. So we already talked about that. And we already talked about how carbon dioxide is the most important factor affecting ventilation and how oxygen normally doesn't. Now, these are not the only parts of your brain that can affect respiration, though, too. So notice we've got higher brain centers that can change respiration rate. What did we say at the beginning is, what muscle is driving inspiration?
Diaphragm.
The diaphragm muscle. And the diaphragm muscle is actually skeletal muscle. What do we know about skeletal muscle?
Lots of things.
Well, okay, let me be more specific then. What do we know about how it's controlled versus smooth or cardiac muscle?
You can control it.
Right, it's voluntary, right? There's a voluntary control. Now, those brain centers we were looking at before, the ventral and dorsal respiratory groups, sort of like your autopilot setting. So diaphragm muscle, although it is voluntary skeletal muscle, you have what I think of as like an autopilot switch, right? You don't have to think about your respiration if you don't need to. Your body kind of takes over. But could you change your respiratory rate however you wanted to using your voluntary controls? Sure, of course you could. If you felt like it, you could just start breathing really fast right now for no reason. Or hold your breath because you're bored and you want to see how long you can hold your breath, right? You could do any of those things because there are higher brain centers playing into this. Those we were discussing, your conscious choices, falls under this category right here of cortical controls. Voluntary breath holding. You can really breathe at whatever speed you want once your cortex takes over, including holding your breath, which is of course not a normal thing for your body. Your body wants to have sort of normal continuous breathing, but if these higher brain centers decide that you want to hold your breath because you're underwater or whatever, then you can. When I was in college, my campus job was lifeguarding at the pool in the rec center, which is a super boring job. And so one of the things I did to pass the time was see how long I could hold my breath. And I once got to 3 minutes and 5 seconds. Breaking 3 minutes was a big deal for me. I think aside from my kids and my doctorate degree, that was probably my greatest achievement. But that's an effect of, an example of using the cortical controls to change ventilation rate beyond what your medulla would have you do. You also see up there hypothalamic controls, or hypothalamus as a portion of the limbic system can influence breath, or ventilation rate I should say, in response to emotional changes. So it says here, breath holding that occurs during anger or gasping with pain. Okay, those are all emotional responses affecting respiration coming from the hypothalamus. Can we think of any other examples?
When I get nervous when the doctor's listening to me breathe, then
Sure.
I screw up my breathing.
Yeah. The hardest time to breathe normally is when someone says to you, just breathe normally.
Yeah, and you're like,
Okay, like this?
yeah,
Am I doing
exactly.
it?
I start breathing really deep.
Right. Yeah, exactly.
Mhm.
Or laughing would be an example too, wouldn't it?
Mhm.
That's, it's an emotional response, but it's really what it is coming from your respiratory system. So we can think of some other examples there too. Other receptors that are influencing how we breathe. We have pulmonary irritant receptors. So when an irritant is inhaled, that can affect how you breathe too. There in the bronchioles, the small little airways in your lungs, if they detect an inhaled irritant, they can send a message back to the brain that stops further inhalation and promotes reflexive constriction of air passages. But we can state this more simply. When you inhale something irritating to your lungs, what does your body do? You cough, right? Your lungs don't want you to breathe in any more of this irritating air. They want you to push it out. And that's what the coughing is. You can probably include sneezing in the same category, although the sensation is a little bit different, right? But you breathe in, say you're camping and you breathe in too much smoke from the campfire, right? Cause you to start coughing. That's a reflex from these pulmonary irritant receptors. We also have something called the Herring-Brewer reflex, which is also known as the inflation reflex. There are stretch receptors in the pleura around the lungs. So when the lungs inflate really large, these stretch receptors are activated, and this is an inhibitory reflex, meaning when the stretch receptors are activated to a given degree, they shut down further inspiration. What do you suppose the point of this is?
Stop breathing in the bad, whatever.
Well, we've moved on from the irritant stuff. This is a different one. If your lungs are sort of like a balloon, and inhalation is like blowing up the balloon, is it possible to blow up a balloon so large that it pops?
Can you do that to your lungs?
Well, turns out you can't, and this is why. Okay?
Okay.
This is a protective mechanism to prevent overinflation. So that when your lungs reach a given degree of inhalation, your brain is shutting off further inspiration, further inflation, to prevent that sort of damage. So however deep you can breathe in, when you get to the end of that range, it's not necessarily because everything is maximally large in your body, but more because your brain has shut off any further expansion. So here we've got our respiratory groups there in the brain stem, and we see all of the different factors that play into its decision about how to control your ventilation rate. Biggest thing, especially when you're on autopilot, are those chemoreceptors, checking for the pH of our bloodstream usually, regulating based on that, although they can check oxygen as well, it's just not that common. Other things that can affect it, we saw higher centers like the cortex and the hypothalamus can affect ventilation rate. These can be in either a stimulatory or inhibitory way. There's that Herring-Brewer reflex we were just talking about. When the stretch receptors are activated, it inhibits further inspiration. That's what the minus sign means there. Our irritant receptors do the same as you inhale something irritating, and we forcefully eject that through a cough or a sneeze. One thing that we haven't talked about yet are receptors in muscles and joints. Because, of course, one of the more common times that your body increases its respiration rate is during what? Exercise, right? Breathe faster when you're exercising. And based on what we've talked about already, the implication would seem to be pretty simple. When you exercise, your muscles are metabolizing. That creates carbon dioxide, and our body responds to those rising CO2 levels by breathing faster. But it actually doesn't work like that. Our body makes these changes to ventilation rate before the pH is ever affected. So they're preventative measures. So we have, I think it's on a later slide, it says that the levels of oxygen and carbon dioxide in your bloodstream remain very consistent during exercise. You don't wait for CO2 to go up, respond to it, and then bring it back down. You make anticipatory changes to ventilation rate. And the way that you can do that is because you're getting communication from those working muscles and moving joints of your body that your brain interprets as, okay, we're exercising, we need to increase this ventilation rate here. So everything is staying remarkably steady inside your bloodstream. Obviously, some of that's coming from the brain too, because your brain knows that you're running or lifting or doing whatever, okay? And that feeds into, among other places, your respiratory centers along with the info from your muscles and joints, and you make anticipatory changes during exercise. Besides exercise, what can affect our breath rate? Something people around here are used to.
Altitude.
Altitude, sure. If you go up into the high places in the mountains, you can possibly notice that even your resting breath rate is going up. And if not your resting breath rate, at least with very minor activity. But most of those places you've got to hike to around here. We don't have roads in the high mountains. But if you travel quickly, and this just means not over a period of days or something, but you take a car trip up high, 8,000 feet or greater, and your body starts to notice these changes in the partial pressure of oxygen pretty quickly and make adjustments as a result. Also at elevations like that, you may be at risk for what they call acute mountain sickness, also called altitude sickness, which is as a result of lower partial pressure of oxygen in the air. Remember, there's not less oxygen in the air at high altitudes, it's just the lower total pressure results in a lower partial pressure of oxygen and therefore a lower oxygenation. Has anybody ever had this?
No, but I had a friend that had it when we hiked to Bomber Mountain. Like, we thought we were gonna have to, like, her husband was like, I think I'm gonna have to run down, get the horse, come back up, get her. Like, 'cause
Yeah.
she was really sick.
When I was living in Texas is when my mother-in-law moved to Denver, and so the first time we ever went up there to visit her, this happened. It ranges in severity, so your friend was really sick. I just had a killer headache. So there's all kinds of different possibilities. Headaches, you get shortness of breath, so you're breathing more rapidly. Again, that's as a result of lower oxygenation. You can get nausea, even dizziness. In severe cases, this has been known to result in death from cerebral and pulmonary edema. Edema just means swelling, fluid retention. And of course, cerebral edema would be that in the brain, pulmonary in the lungs, right? So one of the major symptoms that they talk about is high altitude pulmonary edema. The acronym for that is HAPE, right? They mention that from time to time. So the best way to deal with these quick changes would be to, if you suddenly find yourself at a high altitude, to take it easy and not push yourself physically too much. Make sure that you're staying well hydrated, and there are herbs and things like that that can help with circulation also. I don't know if you guys remember or heard the story, but a couple of years ago, the Pope was going to be traveling to Ecuador or Peru, one of those places where it's real high up in the Andes Mountains. And the local remedy in South America for that kind of thing is coca leaves. And they sell teas from it. You can buy the actual leaves. And in South America, that's a normal thing, but to the rest of the world, it's like kind of taboo, because that's, of course, what they make cocaine out of. That's a concentrate made from those leaves. And so the Pope said that he intended to deal with the altitude by chewing the coca leaves, and people were like, don't do that, you're a Pope, you're doing cocaine. But it's very different. It's legal, the whole deal. I think he ended up not doing it. Other disorders of the respiratory system, we've got this family of disorders here called chronic obstructive pulmonary disease. Again, we see something that is not one single thing, but rather a group of diseases that can fit into this category. The two most common examples of COPD are chronic bronchitis and emphysema. Both of them anyway, are considered progressive and irreversible, which we saw before with congestive heart failure. That means it doesn't go away and it just continues to worsen. They are different diseases, but they have similar risk factors and some similar symptoms as well. So you see here, dyspnea, that means difficulty breathing, so they're struggling for breath. Frequent infections, chronic cough, all play into it. And they both have the same risk factors. 80% of COPD patients have a history of smoking. In the remaining 20%, it's probably going to be in places like large cities where pollution is a factor, or people who have occupational exposure to chemicals and smoke and that kind of thing. We can include, in some ways, asthma into this group too. Do you remember earlier on in this chapter what we said obstructive pulmonary diseases were versus restrictive?
Isn't that there's like an actual obstruction blocking a little alveoli? Or?
Not necessarily. You might see that in, for example, the chronic bronchitis example of this, but not in emphysema. An obstructive pulmonary disease is one that affects airway resistance, whereas restrictive is one that affects lung compliance. So anyway, we're affecting airway resistance here. And didn't we say that asthma affects airway resistance too? Yeah? And chronic means for a long time. Most people who have asthma have it either for a long time or for their whole life, right? But it doesn't fit in the way that it is episodic, meaning it comes in attacks and stuff, whereas these are there all the time. About to do something. We're almost to 30 minutes.